Welcome to this episode of EAUTV. Today we are here with Saeed Dabestani. He's Associate Professor at Lund University in Sweden, a urologist consultant. And we just had the discussion of the last game changer of EAU25 that is called AURORAX. This is a prospective registry biomarker-driven analysis based on high-risk clear cell RCC patients. Can you, Saeed, tell us a little bit of what you presented today?
First off, thank you for having me. I'm really happy to be here today. So yes, the game changer session, I was really happy to come and present our study. What we have done is that we have looked at something called glycosaminoglycans. These are sugars that are found on the cells in the body, and they've been shown, if you measure the profiles, so many of these glycosaminoglycans, so-called GAGOMs, they've been shown to actually have some part in the dysregulation during cancer compared to healthy controls. So what we have done a prospective multicenter trial to assess whether we can use GAGOMs in a scoring system to determine if the patients have a recurrence after treatment for clear cell RCC.
Okay, good. And what were your results today?
So the key findings were that when we followed our patients, we had about 16% with a recurrence. And when we looked at these from a sensitivity and specificity perspective, we found out that the GAGOM score test, shows 90% sensitivity and 51% specificity. And that translates into 97% negative predictive value. So we can, with the test, show that we can, with high probability, rule out cancer during follow-up. And it's a urine-based biomarker.
So what would you say your patients, like you have a negative test, and what does that mean? So
in clinical practice, and we're planning to validate our findings from this study in a study that is part of the study design. But for the patients, if this comes to clinical utility, we can have the patients do their first scan after their curative surgery. If it's clear cell RCC, instead of having the regular scan follow-ups, we can either omit the CT scans and in favor of a urine biomarker, which is much more convenient for the patient, or we can, in the high risk or intermediate risk patients, we can halve the number of CT scans. So for the clinician, it rules out cancer with high chance. And for the patients, it means less anxiety, it means less unnecessary imaging, less radiation exposure, and for the healthcare system, it of course means
less hassle.
better costs,
right.
better costs.
Less anxiety.
Yes.
Okay, so can you tell us a little bit, since you have a short follow-up, actually 15 months seems a little tight.
Yes.
It's a little over a year, and you have a high rate of false positives so far. Do you think that might change within the next 12 months follow-up?
So the way the study was designed was to find if the test is valid as a test for diagnostic precision in this context. So we designed it with a short follow-up intentionally. The 18 months of maximum follow-up for each patient was intentional because the test is about the diagnostic accuracy of the test. With that said, we do plan to see if we can extend the follow-up for these patients, both primarily for the prognostic value of this test, but in theory, we think that we would probably increase the specificity of the test and lower the number of false positives.
It's a matter of time, maybe within the next analysis. You may strengthen your results, basically, right?
Agreed. What I think is also important to mention is that we also measured the lead time. So the time from where the GAGOM score was measured with a positive test until the patient had a radiologically confirmed recurrence. And that time, we show that we can actually reach early detection with about 4 months median value. That's also another benefit to these patients, just to have mentioned that as well.
Anxiety-wise, patients get happier.
Of course, they don't have to wait. I agree.
Can you tell us a little bit about the further developments? What is the timeline that we are going to see things happening?
So we were fortunate enough just yesterday to find out that the paper has been accepted in European Urology Oncology. So it is in press release date to be determined. Mm-hmm. That's very happy news for us. With the second cohort, which aims to validate our current findings, right. The last patient is being recruited at the end of April of this year. That's the estimate. And we hope to have the second cohort validating our findings analyzed and finished by the end of 2025. So hopefully we might be even invited back, Next year to present the second cohort validating our findings.
That's good to know. I'm really looking forward to these extremely interesting results. Yeah. Thank you for listening, and we will follow up with you next year. Thanks, Saeed.
Thank you so much for having me.